All right, super. So welcome to the afternoon session. We've got a really different afternoon lined up here. I think a really exciting opportunity to advance our discussion at a provincial level on serious illness conversations. We recognize that there was a tremendous interest in this session that followed this 1-hour lecture, and I think you've all read and hopefully heard this before, that we do anticipate, and I think the panel here can tell you how this program and training is going to roll out more widely on the provincial level. But given that this is a new initiative, the rate limiting step was the number of facilitators available, and hence the limit at 100. So thank you for your patience with that process. But recognizing the importance of this topic, we thought that it would be great to have a 1-hour session dedicated to some instruction as an introduction that the whole conference group here would benefit from. So we have our panel this afternoon, Dr. Rachel Carson, Dr. Gayleen Hargrove, and Dr. Morgan Lamb. I'll say a few words about Dr. Carson, and she's going to introduce her co-speakers subsequently. So Rachel's a good colleague of ours over on Island Health. She's well published and studied in the area of chronic disease and end-of-life issues. I still quote you commonly with some of your publications. Thank you for the information. She's helped establish the full-service renal program, which is now up and running in Nanaimo. So no small task there for 4 years. And I didn't know this about you, Rachel, that initially trained as a family physician. I knew you were an engineer, so she wears a lot of hats. She did her training in internal medicine in UBC and later went on to do nephrology at University of Western Ontario. She has a long interest in end-of-life care and advanced care planning, and we're keen to hear what you have to say. Okay.
So thank you, Caroline, so much for that introduction. And I have to realize I have the clicker. Where is my clicker? Thank you. So welcome, everybody. I think if I can just ask you to, before we really get going, there is, if you can go to the event app and open up the program, the Introduction to Serious Illness Care Conversations, and fill out our pre-live poll questions. That just tells us a bit about who's in the room and what your feeling of confidence around having these conversations is, and then the participants will be doing a post-evaluation as well, but that makes a big difference for our evaluations and our accreditation, and also really to help us plan this to go as well as possible. So I think I want to just take a moment to actually read a poem, and so this is a poem by Raymond Carver, and it's called What the Doctor Said. He said it doesn't look good. He said it looks bad. In fact, real bad. He said, I counted 32 of them on one lung before I quit counting them. I said, I'm glad I wouldn't want to know about any more being there than that. He said, are you a religious man? Do you kneel down in forest groves and let yourself ask for help when you come to a waterfall, mist blowing against your face and arms? Do you stop and ask for understanding at those moments? I said, not yet, but I intend to start today. He said, I'm real sorry. He said, I wish I had some other kind of news to give. I said, amen, and he said something else I didn't catch, and not knowing what else to do and not wanting to repeat it and to have to fully digest it, I just looked at him for a minute. And he looked back. It was then I jumped up and shook hands with this man who had given me something no one else on earth had ever given me. I may have even thanked him, the habit being so strong. So I just want to take a moment, first of all, to thank you for being here and to thank the organizers for including this presentation and workshop in the conference. And for you, the audience, for demonstrating how very high the appetite is for skill development in this area. I think you should know that this is the biggest workshop BC has ever run. So thank you, kudos to you for showing up on a Friday afternoon. I also want to pause and just take a moment to say, what's this really all about? So the title is More Earlier, Better Conversations. But I think if we step back, it's actually really about making sure our patients' wishes at the end of life are expressed and heard and respected. And this is one component of that process. And stepping back even further, why do we do the work we do? And I think for most of us, it's because we want to relieve suffering. We want to relieve the suffering of our patients. We want to relieve the suffering of their families. And I think, from speaking for myself, we want to relieve our own suffering. And I think this is training and skill development that can relieve our own suffering to a degree. So I'd also like to do a few acknowledgements to the BC Centre for Palliative Care, which has shown a lot of leadership and has really provided the infrastructure for implementing this program in BC. In particular, Dr. Gillian Files and Elizabeth Bedard-Huber, who are the clinical leads for that process. To the BC Renal Agency and the organizing committee, in particular, Sarah Thomas. Sarah, where are you? Sarah has done heroic work at the back there. This is organized chaos, but there is a method to the madness, and Sarah has really been the backbone of making this happen. And Charles Hoare, who's also at somewhere here, who has facilitated the technical components. And finally, not listed here, but exceedingly important, the facilitators who have come. These are not actually renal clinicians for the majority. They've actually come from other disciplines. In fact, we have 2 people who came from the island voluntarily to donate their time because we all feel so passionate about this. So I don't believe we have significant financial disclosures. I will make a disclosure of my own that's a bit more personal in nature. So this is my family. This is a picture taken on a little island off the coast of Nova Scotia, and this was last summer. And this is my dad's backyard. My dad has significantly metastatic cancer, and I am passionate about this, that I use this tool, I use this conversation guide in my practice multiple times a week, and I can tell you this thing is the bomb. It works. And it worked so well, and it was so important to me that I sat with my dad on that little island in the deck the day after this photo was taken, and we went through this guide. And we wrote everything down because I wanted to know in my heart that his wishes would be expressed and heard and respected, and so that we can do the best job we can in helping make sure his wishes are respected. So what we're doing here today is to make sure that we can explain, and you can ideally give back to us the rationale for improving how we do this work, how we talk about serious illness and patients' values and priorities in that context, to define the serious illness care conversation intervention, this tool, to practice using it, and that's the participants who've actually registered for the workshop, in using person-centered, structured approach to a goals of care conversation. And then at the end, we'll ideally talk about how we might plan to trial it in your practice clinically, and to talk about how we might implement it in our renal programs. So we'll go to the video now. So this is a video of Atul Gawande, who's the medical equivalent of a rock star in my mind. So this is a surgeon at Harvard. He's a professor. He also happens to be an author who writes for The New Yorker and publishes best-selling books. And he's the fellow who helped implement the worldwide safer surgery checklist. So he's got a few accomplishments under his belt. And I was lucky enough to go with a BC team to Boston to learn from the group of people that he has assembled to create this and put the full academic machinery of Harvard and their libraries, et cetera, behind developing this. So let's go to the video.
These are hard conversations. I've blown them many times myself. I've not known what to do. And with this study coming out from the Mass General where the patients had seen a palliative care physician, I realized that the gain they'd gotten was that really they'd seen 6 people who knew how to, that's the staff at the Mass General for palliative care, that they'd seen one of these 6 people who knew how to talk to them about the end of life. And so what I did was I went to those doctors and just said, I'm really bad at this. If you had to make a little list for me of what it is that I should talk about with people facing these problems, what would you put on that list? One of the doctors that I spoke to was a palliative care physician at the Dana-Farber Cancer Institute named Susan Block. And Susan encapsulated it, I thought, the best for me, at least in a way that I could use. She said that there were 4 things that she has as a little mental list in her head that she wants to talk about with a patient who's terminally ill. Number one, do they know their prognosis? Number two, what are their fears about what is to come? Number three, what are their goals? What would they like to do as time runs short? And fourth, what are the trade-offs they're willing to make? How much suffering are they willing to go through for the sake of the possibility of added time? That list was really interesting to me. It was not a list asking, do you want a ventilator or do you not want a ventilator as you come to the end? Do you want your heart shocked? Do you not want your heart shocked? Her point was, if you tell me the answers to those questions, I can make a recommendation to you that says, you would not want this toward the end if these are your goals. Our misconception is that the conversation is about hard choices. Really, it's a conversation about asking people about what they want to look forward to as time runs short and what they fear the most. And the second misconception is that that arriving at what we want at the end is a kind of epiphany. Sign here, do you want hospice, do you not want hospice? It's not an epiphany, it's a process. It's a series of conversations and ups and downs as we go through a very hard series of sequence of things that happen to you as you become ill and have things come to an end.
So, and I think that was sort of the genesis of some of the work they did. As I said, they put the full Harvard machinery behind the evidence review and looked back to see what all the work that other people had done in the past, and then moved forward with sort of an optimized version of how we might approach this. So I just want to take 2 minutes, sit at your tables, and I want you to think about a challenging serious illness conversation you have had with a patient or a family, or maybe one that you've witnessed. And we're going to do it briefly. What's one thing that went well and one thing that you think might have gone better or differently? So just take sort of 2 minutes and just chat with your table mates about that. I shouldn't hear silence. So I'm going to stop you there. It's always a risk to ask a group of people in an audience to start talking and then try and get them to stop talking about a topic like this. But bringing this back, how do we define serious illness? And I think if you look at these criteria, which was an academic research-based criteria, is there anyone in this room who doesn't care for patients who have at least one of these three items in their description? Certainly, we know that renal disease has a significant burden of death, certainly for some of our subpopulations. It has a very strong negative impact on quality of life and functioning, in particular for those who are on dialysis. And we know that it is highly burdensome to a person and their family, and the Renal Agency's done some work around what that burden is. So what's a serious illness conversation? What are we talking about here? So it's a conversation, as Dr. Gawande said, that's really about values and goals using a structured format, that it shares prognosis. And I don't want the non-physicians in the room to shy away from that idea. So prognosis is historically taught as something the doctor does. In fact, functional prognosis or description of prognosis as uncertain is very much within the scope of nurses and social workers and other clinicians. And I think it's important that we embrace our collective expertise in that area. It de-emphasizes the menu of procedures. So as he said, it's not about asking whether or not someone wants intubation. It's about asking what matters to them, and then we can advise them what their values, what would be consistent with their values and goals. It occurs early, so more earlier better. It provides a foundation for that process, that arc over time. And it should be revisited, and it actually can be therapeutic, even if a decision isn't made. And sometimes I would argue in particular if a decision isn't made at that day. It's not about, again, the menu. It's not specifically about code status or a most conversation. It has a relationship to that, but it's not the same. And it can be used to inform medical decisions and planning, even when the patient already has a most. So I think it really needs to be thought of as a process. So I actually try to think of the most. Let's just spend a moment on that. Does everybody know, anyone who doesn't know what a most is? So code status, basically. So it's the updated a medical order for scope of treatment, which is, I think, increasingly used across BC instead of code status. And so I think of the most as the cherry on top of the sundae, the maraschino cherry, which frankly is just not that good. And so the real good stuff is the ice cream and the fudge. And that's where the richness, where the human component, where the deepness of our relationships with our patients comes into play. And that's where I believe I get the most meaning in my work. And so that's where the ice cream is. If you think of what's the point of a most order without those conversations, it's just about as good as a maraschino cherry without a sundae. We also know that aggressive patient care for those with advanced illness is actually harmful. We know that patients have lower quality of life when they're exposed to aggressive care that maybe isn't consistent with their values and their wishes. We know that it causes them greater physical and psychological distress, and that's well demonstrated in the literature. We also know that for their families, there's greater depression, lower satisfaction, and greater difficulty in the bereavement phase after the patient's death for those who maybe have what we might call inappropriately aggressive care. And so there aren't that many nephrologists in the room, but there are some. So I want to focus on nephrologists. This is a very recent paper from this year. This actually was a qualitative study from the States looking at, I believe it was 35 nephrologists. And in fact, it asked them to describe their levels of distress. And they found out that the early adopters, those physicians that routinely included conservative management or supportive management in their discussions with patients, actually had lower levels of moral distress. And so as I went back to talking about relieving suffering, there's actually research evidence that this process and this skill development that you're here participating in can actually reduce our moral distress. So we also know that historically, so that's a recent paper, we know that historically nephrologists shy away from this very much. We don't want to touch this at all. So these are two Canadian papers from Winnipeg and Edmonton, and they asked whether or not, these are dialysis patients, whether or not their physician had talked to them about how much time they had left to live, and the vast majority had not. And then they asked the patients how important it was for them to know about their prognosis, and whether in fact they would like to know their actual life expectancy on dialysis, and that is just about as striking a contrast as you can imagine. So this is a very big unmet need. We also know that many patients don't discuss their goals with clinicians, and this is a cancer population, but what was interesting to me about this is the fact that in an advanced cancer population, the mean time for the first end-of-life discussion was 33 days. And when you think about the values and the goals people have, to only give them 33 days to prioritize those goals is actually a failure on our part. And so part of this, moving this more earlier better, is actually a gift to our patients to give them a gift of time to focus on what matters. We also know that this is true across other comorbidities. So this is a Canadian study that looked at cross-Canada acute care hospitals, and they interviewed the patients specifically about their expressed preferences and wishes and values for end-of-life care, and unfortunately, only 1 in 3 patients had a concordance between what they wanted and what was in their medical record. So when we think about expressed and heard, how can we respect those wishes, even if they've said them, if we only get it right in the medical record 1 in 3 times? And then, lest you think I'm just pulling this from the literature, this is 2017. We asked a group of family council members. These are people who are families of those in residential care, and these are actual quotes from those people. And I think the one that really hit me is that there was a strong desire to have straight talk about medical realities. They talked about Googling because no one told them. And they talked about how empowering it was to know that their wishes would be respected. We also know, zooming out to the BC picture, that although the majority of patients feel this is important, they don't talk about it with their clinicians. So we know that only, again, 1 in 10 has had that discussion, which reflects very nicely that study from those studies from Winnipeg and Edmonton, showing that 90% of people have not talked to their nephrologist about their life expectancy. So we have an elephant in the room, but I'm quite pleased to see that you can all see it. There are a lot of barriers to do this, and I won't spend a lot of time on that, but we know there are barriers. But we also know that there's benefit, and so we know that having these conversations early and doing it skillfully means that we can enhance the concordance in those values that are expressed and heard and what's actually respected. We know that gives people more time to make decisions and fulfill their goals. It improves quality of life, satisfaction, coping, eases burden. We know that it actually also has financial benefit, which I think is very much secondary, but nonetheless important to our funders. And it improves bereavement outcomes for families. So the bottom line is, people have priorities besides living longer, and they change over time. They want the truth about prognosis, and that anxiety is completely normal for the patient, who may not bring it up to the clinician, and the clinician, who's going to be distressed and anxious, especially if they haven't practiced in advance. We also know that there are straightforward and effective ways to ask about these priorities, and they make a big difference. And so I'm now going to pass over to my colleague, Dr. Hargrove, who's going to introduce you to those straightforward, effective ways. Dr. Hargrove was actually is one of my mentors, so she was my preceptor on my nephrology rotation as a family resident, intern in fact, and she is an accomplished nephrologist who also is the chair of the BC Renal Palliative Care Committee and is leading multiple research interventions, quality improvement interventions, and improvement of bringing us all up a level in terms of our skill in the province in terms of providing this care. So with that, I'll take it over to Gayleen.
Thank you so much, Rachel. You're a very hard act to follow. And yes, I am that old. I mentored her. All right, so this next part of the presentation is to focus on, let's call it the tool. So we've told you that this is something good, something needed. Dr. Carson has very clearly explained the rationale for this. How do we go about doing it? So this is to define what this serious illness conversation is all about. Let's call it the intervention and its components. So it's meant to use a person-centered approach, and we'll call it the guide. One objective is to practice role play, and that is to follow. And then further to that, let's implement it in our practices and talk about how we can implement it into our workflow in our renal programs. What do checklists or guides do? Really, it's a bridge of this gap between evidence and real-world implementation. We all have reasons why we can't adapt or implement something that we know we should do. Time, busyness, interrupted workflow, anxiety, lack of skill. We're going to break down all those barriers today. We want to adhere to key processes, and you'll learn that the language in the guide is important. Let's adhere to that. Achieve a higher level of baseline performance. Ensure completion of necessary tasks during complex, stressful situations. As Dr. Carson pointed out, this is an anxiety-provoking situation. There's no question. But like with anything in life, the more you practice, the more you gain confidence about your skill, the less anxious you become over time. And as the studies have shown, this does reduce clinician anxiety, provides content and focus, and we become better listeners. So what are the downsides of using a guide? So just take a moment to think about that. You may not like the idea of using a checklist. However, it does help to keep us on track. So this is the most recently updated Serious Illness Conversation Guide, and I know you can't read the fine print, but really it's meant to be organized in two parts. There's a checklist on the left, so those are the different components, talking about the setup, asking about patient understanding of their illness, getting into prognosis, and so on and so forth. And then on the right side is the actual language used. And this is updated because it's been validated by patients. So in this trial, this looked at patients who basically the answer to the surprise question was no. Now, how many in the room know what the surprise question is? All right, I'm glad I asked. Many don't. I didn't know what it was once upon a time. So it is the following. Would you be surprised if this patient died in the next 12 months? And if the answer is no, that is the patient cohort that was represented in this study. And so the preliminary data was that the training program was viewed as effective and feasible by the clinicians who used this tool, the guide. The conversation guide was felt to be acceptable to patients and clinicians. Patients found it worthwhile and report enacting concrete behavioral changes as a result. So it impacted the behavior of the patients, actually. In deceased, intervention patients compared to the control showed the following. Greater proportion of patients have at least one documented goal discussion before death. As was shown, many don't have any documented goals discussion at the time of death. And the discussions documented in more retrievable locations so that all the clinicians could access it. So the EMR, and there was more comprehensive information contained within these documents. And the conversations were actually begun 3 months earlier compared to the control group. And one of the barriers we often put up as clinicians is to say to ourselves, well, if I introduce this too early, I'm just going to increase the patient anxiety. Well, in fact, studies have shown the opposite. So this looked at the intervention group versus the control. Again, the same group of patients where the answer to the surprise question was no. And in fact, so on the x-axis you have weeks since the baseline survey, and you can see that clearly there was a departure of the lines between control and intervention group, where the anxiety clearly decreased in the intervention group, and that was sustained. So a systematic intervention to improve serious illness communications in primary care. So this implementation trial effectively showed that training was feasible and effective. More and better serious illness conversations did occur. It was more accessible and comprehensive information found in the healthcare record. And they also looked at how much time was involved. So time is a barrier. So doctors, it took approximately 22 minutes. And for nurses, yes, nurses used this. Nurses gave prognosis and all the other bits and pieces. Their time was 26 minutes. And the conversations were conducted by multiple team members, almost 42% of the time. So for a patient to realize that every team member feels this is important to engage in this conversation, that's going to increase the trust in the patient, in their healthcare team. It's going to reduce anxiety. So, now time for the Shakespearean actors to take the stage.
All right, so just to introduce this part, this is Dr. Gillian Files, who from the BC Centre for Palliative Care, who in her pre-centre career was a palliative physician with the BC Cancer Agency. And she tells me her husband is a Shakespearean actor, so we expect great things, great things. So we're going to demo this. So this is us standing up and saying role-playing is hard, but we're going to do it in front of all of you, so I hope you appreciate how much our hearts are pounding. But we want to give you a real live look at how this might go. So if people, actually we don't have the participant packages on the tables quite yet, but this is a kid, so Jillian's going to be a kidney care patient, so I'll just read quickly. I'm going to give you this one.
I threatened to channel Lady Macbeth, but Rachel said I couldn't.
So this, I'm going to play the nephrologist. So she's playing a 65-year-old living with a partner. She has a heavy burden of comorbid illness, including stage 4 chronic kidney disease with an EGFR that averages about 20 milliliters per minute. She's followed in our kidney care clinic, and this is, by the way, based on a real patient of mine. Her previous experience with the healthcare system has not been good, and she's been extremely traumatized after admission for cellulitis 2 years ago, and she left at the end of that admission against medical advice, and she actually describes herself as having PTSD from that stay. She has diabetes, congestive heart failure, atrial fibrillation on warfarin, gout, and her BMI is quite high. This is a routine visit. She's by herself, her partner couldn't come today. And we were actually in the middle of the visit and talking about whether to go ahead with a colonoscopy, and she spontaneously brought up that she would not be willing to put up with that. And then she says, you know what, they should just tattoo "do not resuscitate" on my chest. I don't want any of that stuff. So this is where I, as the clinician, am going to notice that cue and take that opportunity to have a serious illness conversation. So the other thing I'm going to do is I'm actually going to role model something for you. And this is my copy of the guide. You can see, those of you in the front can see I've got sort of Sharpie scribbles on it, and it's laminated because I've used it so much it started to get a little soft from wear and tear. So I carry this around with me in the hospital, and I've done this a few times. All right. So Jillian, thanks for sharing that with me about the colonoscopy. You know, that's important to know, important for me to know, so that as your doctor I can respect you and what matters to you. Would it be okay if we have a bit of time? So my clinic is not too behind. We actually have some time right now, and because this is a regular visit and we have some moments to kind of sort of have a conversation maybe about where things might be going with your health. Would that be okay with you?
Sure, okay.
Okay. And I'm actually going to I've been working on having conversations with patients about what matters to them, and I went to a course, and so I carry around this little cue card just to make sure I don't forget anything important. Is it okay with you if I just have this with me?
Sure, Dr. Carson, whatever you need to do.
Okay, great. So maybe you can actually tell me about your understanding of sort of where you are with your health and your kidneys and your overall medical issues.
Well, I know I've got a lot of health issues besides my kidneys. I know my heart's really bad. I don't think I'm going to live forever. I get that. I know that you might be talking to me some point about dialysis, but I don't think I want that. I don't like being in hospital, and I don't think I'd want that, even if it means I would live longer.
Okay, thank you for sharing that with me. What kind of other information do you want from me about your health? Some people tell me they want to know sort of how long they have to live. Other people ask me to sort of tell them what to expect in their daily lives. What kind of information would you like from me?
Well, I want to know everything. I need to know everything. And that was one of the problems when I was in the hospital. People didn't tell me stuff. So, yeah, tell me everything you know.
Okay, I will. So I think, I certainly hope that you will continue to live for a long time and live well with all the medical issues that you have. At the same time, I worry that you could get sick quite quickly. And I think it's important that we have this conversation in advance, talk about what matters to you, because if you get sick quickly, you could be very sick. And to the point, where we need to plan ahead for what matters to you.
Okay. All right. What do you mean about getting really sick?
Well, as you said, your heart and your diabetes and your heart electrical system and your kidneys are all compromised. And so we know that when that happens, sometimes you can get sick very quickly and end up having an acute episode where you might end up in the hospital or you might end up not surviving, and it can happen quickly. But I don't know when that will be.
Wow. I wasn't expecting that. Wow. Wow.
So I can hear that's really hard to hear, eh?
Yeah, I wasn't really expecting that, but, I know I need to hear it, and I've been kind of worried about it, but, I know we need to talk about it, but okay.
And I want you to know that, like I said, my hope is that we can help you live well for as long as possible, and we're here on your team to help you do that, okay? But I think it also is a good thing to have a plan B. I know I'm a planner, and I think you're a bit of a planner as well. You talk about how you like to be organized, and it's important to have a plan B in case things don't go as we hope. Okay. Maybe you can tell me a bit about what your most important goals are when you look ahead to a future with your health.
I don't have a bucket list. There's nothing major. I just want to spend more time with my husband and with my pets. I think that's basically it. No big travel plans or anything.
Mm-hmm. Can you tell me a bit about what your biggest fears and worries are as you think about the future with your health in particular?
Well, you know how bad that hospitalization was.
Mm-hmm.
That I never want to go back in. They were very disrespectful. They made lots of nasty comments about my weight. If I got to some point where I couldn't communicate and tell people what was important to me, what I wanted, I don't want that. I'm worried about that. I'm scared about that.
Mm-hmm. And how about what gives you strength as you deal with all these medical issues?
Well, my husband gives me strength, and our pets. I get a lot of love and support from them. So that's it, I think. I'm not a religious person. It's my family.
Mm-hmm. Yeah, and I know they're very important to you, and this is certainly, we can kind of revisit these issues with your husband here. I know he couldn't come to clinic today, but I know how important they are to you and the dogs, for sure.
Yes, especially the dogs.
And you may not have thought of the answer to my next question, which is sort of what abilities are so critical to who you are that you can't imagine losing them or living without them. So if you sort of lost certain things, that would be too much of a loss to who you are. Have you ever thought about that?
I started to think about that after that last time in hospital because it was so awful. And I think that if I couldn't tell people what was important, and if I couldn't read or if I couldn't communicate. So, what if I was in the hospital and I had to go to the bathroom and I couldn't tell anybody about that. That would be terrible. That would be awful for me and humiliating. And I need to be able to communicate and recognize people.
Okay. Yeah. So I hear that interaction, if you couldn't interact or meaningfully communicate, that's a big deal for you.
Yeah.
Okay. How much do you think your husband and your extended family know about your wishes and your goals?
They know how traumatizing the last admission was. We haven't talked about it very much. I haven't told them my feelings about dialysis yet, but I guess we probably should. I just don't know if I can do that on my own.
So maybe that's something we could, ideally I could help you with, and maybe our team here, we could bring you back with your husband here. We could go over that together. The other question that I realized I forgot to ask was that it's a little bit like critical abilities. It's also, what are you willing to go through for the possibility of more time? What are you willing to put up with in terms of our medical interventions and treatments? Have you ever thought about that? Sort of an example would be being in hospital. Are you willing to put up with that again?
I don't know. I don't know if I could put up with being in hospital again. I definitely don't want to be put on machines. I don't want anybody shocking my heart or putting tubes in my throat. I've thought about dialysis because I see what happens, and I don't want dialysis. You know, my mom and my grandma died at home in bed. That's what I want. I don't want any of those machines. I don't even want that colonoscopy you're trying to get me to have.
Yeah, and I respect that.
If I die sooner, okay, but I don't want any of those types of tests.
Okay, and as I said, that means a lot to me, so I can help advocate for you and make sure that we respect those wishes that you have. So thank you for sharing them with me.
I appreciate that.
So, I mean, it sounds to me like living well is important to you. Being at home is really important to you with your husband and your dogs.
Yep.
And that you really value your quality of life, maybe more, that's so important to you that you're not willing to go through some of our interventions that might reduce your quality of life just for the possibility of living a bit longer. Is that right?
Yeah, absolutely. Yep.
Okay. So again, I want to thank you so much for sort of taking, this is a heavy conversation, but it makes me feel like I know you a bit better, and it makes me feel like I can care for you more fully, and that I want you to know we're on your team in this clinic. Okay. We're with you no matter what.
Okay. Thanks, Dr. Carson. I appreciate you talking to me about this. I know we had to talk about it, and I feel better that it's out in the open now.
Okay.
And maybe you can help me talk to my husband.
I would be honored to do that. Okay.
Thank you very much. Well done. I wanted to highlight the pause, that awkward silence that we often talk ourselves through. So the reason I highlight that is that part of the guide is to allow for those silences. It takes a lot of time to process the fact that a patient is possibly facing the last year of their life. So as you go through the role play yourselves, please allow for those silences and by all means listen. So just think within your own head, or you can even discuss briefly, please, briefly, what was effective about that conversation? There were elements that were quite unique, perhaps, compared to how you usually conduct conversations with patients. What was effective? What was ineffective, if anything? You'll have time later to consider, too, as you do your role playing. And so you notice that Dr. Carson was very open and transparent to the patient about using the checklist, okay? And my experience is our patients appreciate our honesty. And they also appreciate the fact that you just don't want to miss anything. And yes, it is challenging. It might be somewhat of a barrier to that personal interaction, but again, you're keeping yourself on track by using it. And again, how is this different from or similar to how you're conducting conversations in your own practice? So again, this is the guide itself. You saw it exemplified here in expert manner. And, but my experience as well, I use it like Dr. Carson does. Sometimes I stumble, even after I've used it several times, and it's based on how a patient might react. But that's okay too. We're all human. So the first part is setting up the conversation. So in a way, you're asking permission. I'd like to talk about what's ahead with your illness and do some thinking in advance about what's important to you. Again, this is not about getting at a code status. It's talking about what's important to you. And to ensure that when I know what's important to you, I will therefore provide the care that you want. The goal is to make sure that I have all of the information I need about what matters most, so that I can provide the best support to you and your family, and especially if you're in the position of not being able to decide for yourself or speak for yourself, that your family knows your wishes as well. Assessing the illness understanding. This is very important. Often, I know in my own training, I would blurt out what the diagnosis was and then blurt out what the prognosis was. I wouldn't actually ask the patient what his or her understanding was and then sit back and listen. So what is your understanding now of where you are with your illness? Fairly broad-based question. And how much information about what is ahead would you like from me? And, different patients will respond differently. Some do want to know time. Some want to know about what's ahead in terms of what they're going to lose, what functions they're going to lose. What if I can't drive anymore? What if I can't live in my home anymore? All of these things. And some want to know both, time and function. So this specific language, I wish, I worry, it's very effective. So you notice that Dr. Carson used I wish, I worry, I wonder. Okay, so things are uncertain. We aren't the best prognosticators, but when a patient hears you say that you're worried about something about their illness, about what may lie ahead, they seem to perk up. And to state that you wonder if we prepare now well in advance of when things may really decline quickly, that's going to improve the care we give you. It's going to be in alignment with your wishes, your goals, and your preferences. And again, this language, I wish, I worry, I wonder, okay? Patient says, will I be able to make it to my granddaughter's graduation in 1 year? You respond, I wish things were different, but I worry that time might be shorter than that. I hope you can, but I worry that it may not be possible. I wonder if there are things that we can do to prepare you in the event that you can't be there. Here are some helpful phrases, a pragmatic approach, if you will. So I'm concerned that in spite of treatment we're giving you, I might have to share some more difficult information with you soon. I'm worried that even with aggressive treatment, we might be getting to a place where we can't control this illness and time may be short. We need a plan B. We're in a different place now. Maybe cliche, but patients understand this cliche. Hope for the best, but plan for the worst. Expect an emotional response. Allow the silence. It's often therapeutic to give a patient time to process. And if a patient becomes very emotional, don't dismiss it. Actually, explore it. You seem really upset. Tell me more about how you're feeling. You seem surprised. Is that different from what you were expecting to hear? I know this can be really hard to hear. Tell me about what you're thinking. What are your most important goals? You heard that come out. Biggest fears and worries. These can be very illuminating. Again, this is the language of the guide. Sources of strength. So this can be a time of positive reflection for the patient and you as the clinician. What gives you strength as you think about the future with your illness? For some patients, it may be their religious or spiritual beliefs, their faith, family and community support. Explore function, trade-offs, and family. What abilities are so critical to your life that you can't imagine living without them? If you become sicker, how much are you willing to go through for the possibility of gaining more time? And how much does your family know about your priorities, wishes, and fears? Inviting them to share. So, closing the conversation is a summary, okay? So you're actually feeding back to the patient what you thought you heard. Sometimes they may correct you actually and say, well, I didn't really mean to say that, or I've thought about that more and I've actually changed my mind. So summarize and then provide some recommendations based on that summary. So I've heard you say that spending more time with your family is really important to you. Keeping that in mind and what we know about your illness, I recommend that we ask them to come in so that they're aware of where things are at and what your goals are. This will help make sure that your treatment plans reflect what's important to you. And then check in. How does this plan seem to you? I've had patients say to me, I'd like to see the document. I'd like a copy of the document so that I have something to refer to and I can show my family what we talked about. And then affirm the commitment. Provide support. I'll do everything I can to help you through this. I'll be there with you through the end. But don't make promises you can't keep. So document, communicate with other care providers. That's very important. And these are the interdisciplinary team roles. So identify high-risk patients. We've talked about that surprise question and the no response. Prepare the patient with a pre-visit letter or by talking to them. And then use the guide. Provide resources to help the patient speak with their family about it. Recommend follow-up appointments, home care support, family meetings, whatever it takes. And ensure that the documentation is accessible to all care providers and across settings. So there are different adaptations. These are the resources that you can access. And I thank you for your attention and really appreciate that you've stayed here on a Friday afternoon. Thank you.